which is one of the commonest child. Yeah. Every year in September, we usually hold a series of webinars in preparation for our annual Pediatric Hematology Oncology Pre-Workshop Conference. As you're aware, we are in September, and September is the Childhood Cancer Awareness Month. So today's webinar will start us off as we prepare for our third annual pre-workshop conference that will be held on the 24th and 25th of September. This year, we shall hold a hybrid conference with both virtual and in-person attendance. However, there are limited spots for physical attendees, and invites will be sent out to the counties, and the link to the conference will be released at a later date. So the second webinar in series to this pre-conference will be held 2 weeks from before the annual oncology workshop. So the aim of these activities is to raise awareness amongst healthcare workers with the hope to improve on early diagnosis and prompt referral for our cancer patients. So as we know, up to 80% of childhood cancers are curable with early diagnosis and early treatment. So we want to improve the chances of survivals amongst these children. So our presenter today is Dr. Bernice Mukuria, and we also have Celine Kilanya. So Dr. Bernice Mukuria will start us off in this discussion. So Dr. Bernice Mukuria, you can go ahead and load your slide. And Dr. Bernice Mukuria is a pediatric hematologist, oncologist based in Nairobi. She is passionate about provision of excellent quality, holistic healthcare to children with cancer and blood disorders in sub-Saharan Africa, and is keen on advocacy for health system strengthening overall with an overarching aim to improve access and availability of quality evidence-based treatment and care to these children and their families. So just to take us through some bit of housekeeping, so please, we will post our questions in the Q&A section and not in the chat box. And all the questions shall be addressed at the end of this webinar. So I'll invite Dr. Bernice to go ahead and start us off with her presentation. Thank you.
Right. Thank you very much, Dr. Brenda, for that kind introduction. Thank you, KNH Research, for inviting us to talk about one of the 6 index cancers as per WHO and as per WHO GICC initiative of 2018. I'm excited to be here, and yeah, I'll just go ahead and talk about non-Hodgkin lymphoma in children. You realize it's a very wide topic, so I'll try to keep it short and simple. And I see we already have questions, so I'm wondering if there's a question from the introduction. It's about volume. Can you hear me now?
Sure, maybe it was during my presentation.
Oh, okay.
So I think, Bernice, you can go ahead. Yeah, we can hear you. Yeah, sorry for that.
All right, it's okay. Thank you. So we'll go straight into the introduction. So by way of introduction, childhood non-Hodgkin lymphoma, or NHL, as you will see it being abbreviated throughout this presentation, is a diverse collection of different lymphomas that includes all the malignant lymphomas, which are not otherwise classified as Hodgkin lymphoma. It's a most commonly diagnosed pediatric malignancy in sub-Saharan countries, and its incidence is related to endemic malaria in this region compared to other parts of the world. It's a systemic disease, and over the years, there have been advances in histopathology, immunology, cytogenetics, and molecular biology, which have improved our understanding of the biology of these group of diseases, and this has led to more rational classification and treatment of these diseases. So this flowchart is just a summary or like an overview, bigger picture outlook on what the spectrum of pediatric non-Hodgkin lymphoma encompasses. So there's 2 main types. There's a precursor cell lymphomas, and then there's mature cell lymphomas. And when I say cell, I mean it's either a B-cell lymphoma or a T-cell lymphoma. So precursor lymphomas are B lymphoblastic lymphoma or T lymphoblastic lymphoma. These are basically malignancies of the immature B and T cells, and they tend to have a very similar clinical presentation as well as treatment profile to acute leukemia, and in this regard are nowadays regarded as different presentations of the same disease entity. And then there is the mature non-Hodgkin lymphomas, which basically are mature B cell and mature T cell again. So in the mature B cell, there is the bucket lymphoma, abbreviated here as BL, and diffuse large B cell lymphoma as the two most common mature B cell lymphomas occurring in the pediatric population. We also have other mature B cell lymphomas, such as the primary mediastinal B cell lymphoma, pediatric follicular lymphoma, which is quite rare, and pediatric nodal marginal zone lymphoma, which is also rare. Then among the mature T-cell lymphomas, the one that occurs enough in children that you can almost regard it as more commonly in children is the anaplastic large cell lymphoma, abbreviated here as ALCL. But there are others, including the peripheral T-cell lymphoma, not otherwise specified, which is quite rare. And there's also another class of cutaneous T-cell lymphomas, which are also rare in the pediatric age group. So this slide was put in here just to remind us of where the white blood cells come from and where they eventually migrate to, and where we actually get this disease. So as we all know, hematopoiesis begins with a pluripotent stem cell or blood stem cell, which is usually in the bone marrow, and this differentiates. This is a very simplified diagram, by the way, but it differentiates into either myeloid stem cells or a lymphoid stem cell. So the myeloid stem cell will give rise to peripheral blood cells, so the red cells, the platelets, and the white blood cells of the granulocytic and monocytic lineage. Right? Then the lymphoid stem cell will give rise to the lymphoblasts, which will eventually give rise to T lymphocytes and B lymphocytes, which then migrate to which then migrate outside of the marrow into the systemic circulation and eventually settle in the organs and tissues that are displayed in the second picture. So the spleen, the thymus, the tonsils, adenoids. This is just a magnified lymph node, which just shows the complexities therein. So there's a whole vascular structure, and there's germinal, follicular, and other parts of the lymph node. So it's just an overview of the lymphatic system and how complex it is. But from the beginning, where it starts is a bone marrow. I hope that makes sense. In terms of epidemiology, non-Hodgkin lymphomas incidence varies with age and geography. So the incidence of non-Hodgkin lymphoma is more common in the younger child, that is the first decade of life, compared to the second and subsequent decades of life. And in terms of geography, we see more non-Hodgkin lymphoma in younger children, that is below the age of 5 in sub-Saharan Africa, compared to other parts of the world. Worldwide, rather US data has non-Hodgkin lymphoma being the third most common cancer in children after leukemias and brain tumors. And in that region, they account for 15% of all cancers in children who are aged below the age of 20. So compared to Hodgkin lymphoma, which is generally a more organized disease, and which occurs, mostly just in the nodes, non-Hodgkin lymphoma is more common in children under 10 years. So incidence of Hodgkin lymphoma rises rapidly, quite sharply in children more than 10 years, and is the highest incidence is between the 15 to about 25 age group. There's a marked male predominance of non-Hodgkin lymphoma across all the age groups, and among the North Americans, it's seen more in Caucasians than in the Black population. So in terms of initial evaluation, most non-Hodgkin lymphoma in children will present as an aggressive disseminated disease. So prompt referral is mandatory as the potential for life-threatening emergencies is high. So when I talk about aggressive and disseminated disease, I mean it can go to any of the areas highlighted in the previous slide. So it can present as a tonsillitis which is not disappearing. You can have lymph nodes in your axillary area, in your armpits, which are just there and not going away. Many times you'll find that these diseases that affect the lymph nodes will be confused for other more common disease entities such as tuberculosis, especially in our setting. So a high index of suspicion is very important, and prompt referral is even more important as the potential for these life-threatening emergencies is high. So what are these life-threatening emergencies? I'm talking about disease occurring anywhere along the lymphatic chain. So if it's in the thoracic cage near the large vessels, it can cause obstruction of the superior vena cava or even the inferior vena cava, leading to obstructing and causing such things as superior vena cava syndrome, which can be life-threatening. Again, if it can occur anywhere along the lymphatic chain, so that includes the mediastinum, the cervical lymph node chains, which has a propensity for airway obstruction. Again, remember, it's an aggressive disease. These cells divide and grow quite rapidly. So the time from suspicion to occurrence of airway obstruction can be quite short. And that's hence the need for prompt referral of these patients. Non-Hodgkin lymphoma can also present with spinal cord compression, especially if it occurs anywhere along the paraspinal tract in those lymph nodes in those regions, or even again in the thoracic or abdominal cavities, which can be in the thoracic or abdominal cavities. This again is an emergency because it can lead to permanent disabilities. So it's important to intervene promptly, and most times we have to give steroids as an emergency measure, and sometimes there's also a role for emergency radiotherapy. It may also present or cause pericardial tamponade. It can also cause intussusception or intestinal obstruction, especially for tumors occurring in the gastrointestinal tract. And there may also be CNS complications when you have CNS disease. This can include seizure disorders, altered mental state and behavior, etc. Another medical emergency or oncological emergency that we need to be very aware of in terms where non-Hodgkin lymphoma is concerned is tumor lysis syndrome. So again, the cells affected, the malignant cells in non-Hodgkin lymphoma have a very high mitotic index, which is to say that they are rapidly dividing. In as much as they're rapidly dividing, they're also rapidly dying, which leads to an accumulation of uric acid in the child or in the patient's circulatory system, as well as an accumulation of intracellular electrolytes. So this can lead to nephropathy, which can eventually cause death. It can be life-threatening nephropathy or acute kidney injury. At baseline, we need to have a complete blood count. You need to make sure that the child has adequate renal and liver function test results. Lactate dehydrogenase, LDH, is also a baseline marker. As you'll see ahead, it's also used as a surrogate marker for disease bulk. Yeah, so a high LDH correlates to bulky disease, and the opposite is also true. Uric acid is also an important measure to be taken at baseline, like we talked about, TLS and hyperuricemia and its effects on the child's body. So in terms of diagnosis, we need to do an excisional biopsy to ensure that there's optimal quality and quantity of tissue, which will then be analyzed by way of histology, immunohistochemistry, flow cytometry, cytogenetics, and molecular studies. However, this is not usually the case, and most times needle biopsies, usually image-guided, are used more commonly than excisional biopsies for diagnosis, despite the obvious advantages of an excisional biopsy. But again, this varies with institutional protocols and SOPs. Staging workup. It's important to rapidly assess the disease extent, and as this allows us to assign the appropriate therapy and as well as prognostication for the child. So in terms of staging investigations, we need to do a CT study of the chest, abdomen, pelvis, and just ignore the last part of that sentence. It's a typo. And we also need to do a bone marrow aspirate and biopsy to assess for presence or absence of disease in the bone and bone marrow. extensive extranodal disease is quite common in children with non-Hodgkin lymphoma, just a point to note. So in terms of staging, just like many other malignancies, non-Hodgkin lymphoma is generally staged using the St. Jude staging system, which puts the disease as put in 4 stages. So stage 1, 2, 3, and 4, with increasing dissemination of the disease. So stage 1 will be localized disease involving a single lymph node region or a single organ. However, we do not assign thoracic or mediastinal disease or abdominal disease as stage 1. Then stage 2 will be disease that involves 2 or more lymph node regions on the same side of the diaphragm. So like you can see in the illustration, the disease is in the cervical as well as in the axillary lymph node regions, and it's not occurring anywhere else, and they're both obviously above the diaphragm. Then stage 3 disease, stage 2 is also abdominal disease that has been incompletely resected, is also designated stage 2. Then stage 3 disease is when you have disease involving 2 or more lymph node regions or even organs above and below the diaphragm. So automatically generally abdominal non-Hodgkin lymphoma will be designated stage 3 disease. Then stage 4 disease is widespread disease, so involving multiple organs with or without lymph node involvement. As you can see in the diagram, there is also bony and bone marrow involvement, as well as the liver and the nodal sites. So the good thing about the St. Jude staging system is that it accounts for both the primary site of disease and the extent of the disease. Then in terms of risk stratification, there are 2 study groups. There's a German study group and a French study group that came up with these risk stratification tool. So basically, it's the French one, or the FAB-LNB, French and British study group, came up with 3 disease strata. So strata A, B, and C, with A being the lowest risk and C being the highest risk, and B being very heterogeneous and involving many stages as per St. Jude's. Then with the BFM, or the German study group, they came up with up to 4 strata, which also incorporated LDH as a surrogate marker of the disease burden. So you can see the higher strata, R3 and R4, have a higher LDH, and this again correlates with the extent or the burden of disease in the patient. Then in terms of prognostic factors, the biggest one has to be age. Younger children tend to do better than older children, adolescents, and young adults, in that order. Tumor burden is also a prognostic factor. So the higher the tumor burden, the worse the prognosis. Then response to initial therapy has also been used to prognosticate non-Hodgkin lymphoma. So it's a bit different from, let's say, the more liquid hematologic malignancies such as leukemia. We don't look at the presence or absence of blasts, for example, in bone marrow. Instead, we look at the response in terms of size, let's say, of the lymph nodes or the other solid organs to the treatment instituted. Treatment that has been given to this child or to this patient. Then in terms of disease site, there are things like abdominal disease, thoracic disease, or mediastinal disease tend to have a poorer outcome, and that's given a poorer prognosis. Then bone marrow disease, which is seen in ALCL or anaplastic large cell lymphoma, is also associated with a poor prognosis. European studies have shown that anaplastic large cell lymphoma in the lung, in the liver, and in other solid organs is also associated with a poor prognosis, but this has not been the case with the American or North American studies. In terms of assessment of minimal residual disease, so minimal residual disease is basically minimal residual disease assessment is basically an analysis of the disease that remains after you've given the first course of chemotherapy. So for leukemia, for example, if the diagnosis is made by bone marrow, and at baseline, let's say we had 95% of leukemic blasts in the bone marrow, after you've completed induction chemotherapy, you'll repeat a bone marrow and assess. So usually you don't want to have any leukemic blasts remaining in the bone marrow. Basically, you want to achieve remission. So in terms of solid tumors such as non-Hodgkin lymphomas, they're mostly either nodal or extranodal, involving extranodal sites. We want to look at how much these sites have shrunk following therapy. So usually the cutoff is about 80%, depending on the treatment protocol in place. So in terms of therapy, there have been refinements over the years, over the last maybe 5 decades, in the chemotherapy regimens available for non-Hodgkin lymphoma. And there's also been improved supportive care. And this, coupled with the chemotherapy refinement, has led to more favorable outcomes, more so in high-income countries for various reasons. In terms of surgery, it's still confined to the diagnostic biopsy, placement of central venous access, as well as management of complications. For example, when you have non-Hodgkin lymphoma presenting in the gastrointestinal tract, causing intussusception or intestinal obstruction, the role of the surgeon cannot be understated. So we'll talk about the chemotherapy regimens when we discuss specific disease entities within the non-Hodgkin lymphoma spectrum. Then for the precursor B lymphomas and bucket lymphoma, CNS-directed therapy is important and has led to improved outcomes in these diseases or in these disease entities. In terms of radiation, it's not been shown to improve outcomes or to improve survival in both early and advanced disease stages among the pediatric population. Then another thing that has led to improved outcomes has been the prompt and judicious management of tumor lysis syndrome, which includes the hyperhydration with IV fluids, alkalinization of urine if we only have allopurinol in our arsenal to reduce the uric acid, rasburicase, which is also used to break down uric acid directly. And some treatment protocols actually include cytoreduction prephase with steroids and fluids, again, just to reduce the tumor burden before initiating definitive chemotherapy. So like I said before, there's several classes of these non-Hodgkin lymphomas. This table has summarized mostly the mature B cell and the lymphoblastic leukemia or lymphoma entities. I've not included the T cell non-Hodgkin lymphoma in this table, but basically these are the main WHO classes of non-Hodgkin lymphoma. The most common being bucket lymphoma. There's one similar to bucket called bucket-like lymphoma with aberration in the chromosome, in the long arm of chromosome 11, which mostly presents as nodal disease. So when you compare the bucket-like lymphoma with bucket lymphoma, the main difference is in the okay, first there's the aberration in the 11th chromosome, but there's also the clinical presentation, with the bucket-like lymphoma presenting primarily as nodal disease, whilst bucket lymphoma itself will mostly present as intra-abdominal disease, especially if it's sporadic bucket, head and neck disease, non-jaw sporadic bucket, jaw for endemic bucket lymphoma, and bone marrow and CNS. So all this can be clinical manifestations of bucket lymphoma. Then there is the diffuse large cell lymphoma, which is also seen common in children, also mature B cell lymphoma by flow cytometry, which has both nodal and extranodal presentation. So it can present in the abdomen, in the bone. It can be a primary CNS tumor, especially if the child has an immunodeficiency, be it HIV or from other immunosuppressive states. And then it can also present as mediastinal disease. Then we also have the rarer primary mediastinal large B-cell lymphoma, usually a thymic lymphoma, which still turns out to be a mature B-cell, but CD30 positive lymphoma. Usually it presents as mediastinal disease, but it may also have other nodal or extranodal disease, usually in the kidney. Then another one that I think would be important to mention would be the T lymphoblastic leukemia lymphoma and B lymphoblastic leukemia lymphomas. So for the TLL, it presents as a mediastinal mass and also with bone marrow manifestation. So for it to be designated leukemia, it would have to have bone marrow involvement of more than 25%. And for it to remain lymphoma, it would have to be less than 25% involvement of the bone marrow. When we have less than 5% bone marrow involvement, then we will, when staging the disease, the lymphoma, we will not stage it as stage 4, as the bone and bone marrow will not be involved. B lymphoblastic leukemia or lymphoma will present mostly on the skin, soft tissue, in the bone, the lymph nodes, and bone marrow. So with all these sites, you'll get site-specific signs and symptoms. So for example, with intra-abdominal presentation, you can have abdominal pain, you can have trouble with eating, with appetite, so with anorexia. Child can also have nausea, vomiting, constipation. For mediastinal disease, for example, you can come up with, the child can present with coughing, difficulty breathing. With lymphadenopathy, there's an obvious swelling in the lymph nodes, and sometimes may have mass effect. So again, difficulty breathing. We talked about spinal cord compression, so maybe difficulty, pain and paresthesia, eventually progressing to paralysis can be a clinical manifestation. Then, of course, if it presents in the CNS, you can have CNS symptoms such as confusion, altered mental state, altered level of consciousness, seizure disorders, visual disturbances, etc. So let's talk a little bit more about Burkitt lymphoma, as it's one of the more commonly seen non-Hodgkin lymphomas, especially in sub-Saharan Africa. So it's relatively common in children. It's subdivided into endemic disease, sporadic disease, and immunodeficiency-related disease. So endemic disease is essentially what was initially described by Dennis Burkitt and his colleagues back then many years ago, I think in the 60s or late 50s towards the 60s. So it's basically disease that was seen he was studying or working in Uganda. So they were able to note that this disease occurs mostly in malaria endemic regions, hence the endemic subclassification of Burkitt disease. Then there's sporadic disease. So endemic disease is mostly seen to occur around the jaw. But we still see a lot of Burkitt lymphoma that is non-jaw in these very malaria endemic regions. Then there's sporadic disease, which is essentially Burkitt lymphoma that is seen in other parts of the world, aka non-malaria endemic regions of the world. And then there's the immunodeficiency-related disease, usually in association with HIV. So Burkitt lymphoma occurs more commonly in boys and in girls, and it arises from the germinal center B cell transformation, which leads to uncontrolled proliferation. So there are characteristic translocations seen in Burkitt lymphoma. These are seen by way of molecular studies. So translocation 814 is the most common, followed by translocation 28, and then rarely there's 822. And the affected genes are the ones lifted, most commonly the MYC gene or MYC gene. The cofactors that may contribute to the pathologic recombination events include malaria or EBV co-infection, as well as HIV infection. So Burkitt lymphoma has a classic morphologic, immunophenotypic, and genetic. It has classic morphologic, immunophenotypic, and genetic features. And typically, there'll be a population of mature B cells, which will express cell surface CD19, CD20, CD22, and CD10, as well as monoclonal surface immunoglobulin, or IgM, usually IgM. The Burkitt lymphoma cells immunophenotypically do not express BCL2, And this is how you distinguish bucket lymphoma from diffuse large B-cell lymphoma. Otherwise, clinically, they'll present in a very similar way, and treatment is also quite similar. The only difference will be at a molecular level, as well as level of aggression sometimes with DLBCL. The pictures on the left of the slide just show orbital, so non-jaw bucket lymphoma in a child in sub-Saharan Africa. And then this one, the bottom left picture, shows jaw bucket lymphoma affecting the right jaw, again in a child in this setting of ours. So this was usually the more common presentation that you are more familiar with as we were introduced to bucket lymphoma. So this table just summarizes a few differences between endemic and sporadic bucket lymphoma. The main clinical features in terms of peak age at presentation, endemic bucket lymphoma will occur in a younger child, usually less than 5 years old, while sporadic will occur in a slightly older child with a peak at between the age of 6 and 12 years. However, both variations will affect males more than females. So endemic, again, is named after the malaria endemic belt. So this covers Equatorial Africa, New Guinea, and Amazonian Brazil as well, while sporadic covers the rest of the world. Annual incidence of endemic bucket lymphoma is higher than that of sporadic bucket lymphoma, with common tumor sites for endemic being the jaw, the abdomen, the CNS, and CSF. On the other hand, sporadic bucket lymphoma will be seen more in the abdomen, which will affect the bone marrow, lymph nodes, as well as ovaries in girls. They have the same histopathologic features, that is diffuse growth pattern with monomorphic intermediate sized cell and a starry sky pattern. The immunological features are also the same, with expression of CD20 on the surface, as well as surface immunoglobulin M and CD10 with no expression of BCL2. Then endemic bucket has a strong association with Epstein-Barr virus DNA present in the tumor cells, and the translocations are the same for both types. So over the years, I think we have come to the conclusion that it's the same disease. It's just that in the malaria endemic regions, we tend to be exposed to Epstein-Barr virus a bit earlier in life for whatever reason. And that's why we find the EBV DNA in tumor cells more common in sub-Saharan Africa compared to in sporadic bucket lymphoma, which is seen in other parts of the world. In terms of treatment, we have come a long way. Initially, I think in the early years of treatment of bucket lymphoma, there was the use of single agent chemotherapy, usually cyclophosphamide, which did really well, especially for maybe only jaw disease or low stage disease, even in African children. However, with more advanced disease, single agent chemotherapy was not adequate, and there was a high rate of relapse and recurrence of disease. So over time, there has been the newer chemotherapy regimens, which use multi-agent drugs, multi-agent regimens, which use multiple drugs. So again, the backbone is still cyclophosphamide based, but there was the addition of adriamycin, also known as doxorubicin, vincristine, methotrexate at different doses, as well as prednisone. So we are still generally using these regimens that are more in the middle part of this process map, mostly because we are still using low to intermediate doses of methotrexate, and again also to do with the availability of some of these drugs. More recently, we have moved to these regimens that incorporate rituximab, so Coperdem, which still incorporates most of these drugs that were still being used earlier in the multi-agent, at the beginning of multi-agent chemotherapy use, but better outcomes are being seen with the use of high-dose methotrexate, as well as the incorporation of rituximab, especially to high-stage disease. This has led to improved outcomes of this bucket of advanced stage, even in centers where they're able to use high-dose methotrexate as well as rituximab. So high-dose methotrexate comes with its own challenges in terms of use. And remember, I've said that most of us have not been able. By most of us, I mean most of the centers in sub-Saharan Africa, including Kenya and the major factors that are taking care of children with bucket lymphoma. We have not been able to incorporate high-dose methotrexate into our regimens for various reasons, including the fact that it is associated with a lot of toxicity. Starting with nephrotoxicity, it's if the child has any renal impairment, then there tends to be an accumulation of the toxic metabolites of methotrexate. And if there is prolonged impairment, there is prolonged exposure to these toxic metabolites, which can cause myelosuppression. It can cause further kidney injury. It can cause severe mucositis. It can cause hepatotoxicity. And if it's very severe, it can even lead to multi-organ failure. So how we try and mitigate, especially the acute kidney injury, is by hyperhydration. There are protocols for these. We alkalinize the urine using sodium bicarbonate. And then we also try and adjust any other drugs that may interfere with renal tubular secretion. So if the child or the patient is on a penicillin, has been using or is using an NSAID, you want to you look for an alternative pain medication, for example, and then you want to adjust the doses to account for the renal impairment. Then in terms of hepatotoxicity, we have to continue monitoring the serum bilirubin, the ASTs and ALTs throughout treatment and before each dosing of the methotrexate. For severe mucositis, again, it's a terrible complication for various reasons. One, it affects the child's nutrition. It causes a lot of pain from the mouth all the way through to the gut. That whole mucosal surface. Imagine it being very inflamed. It's very difficult to eat. It exposes them to infection and further complicates treatment. So you want to try and avoid all these complications. And a big part of it includes the fluid, the alkalinization of urine, covering with antifungals and antibiotics, just monitoring these children closely and treating it before it gets to a severe point. Then in terms of neurotoxicity, there can be CNS disturbance that includes cortical blindness, hemiparesis, and seizures, as well as chemical conjunctivitis from high-dose methotrexate. So again, we need to closely monitor and intervene early to avoid more permanent complications. And then again, with regards to acute kidney injury, you want to avoid volume depletion. That's why we're going towards hyperhydration. There's an increased risk of toxicity when the child is dehydrated, or if there's a history of previous toxicity with methotrexate, be it oral or intrathecal or IV. And if the child happens to have any extravascular fluid collection, such as ascites or pleural effusion, there's an increased risk of toxicity. So there needs to be a lot of caution if high-dose methotrexate is to be given. So another way that we try to mitigate these toxicities is to incorporate leucovorin rescue to any high-dose methotrexate treatment regimen. This basically means that this is basically to attempt to rescue normal cells and tissues from permanent toxicity from methotrexate. So think about it this way: methotrexate will come in and block DNA synthesis by blocking the hydrofolate reductase enzyme within the cells. So leucovorin does not need the DHF enzyme to synthesize DNA in these cells. So it basically provides like a bypass to allow these cells to continue living by way of DNA synthesis. But it has to be, the timing of its administration is key, as if you give it too early, it will not be able to rescue these cells. If you give it too late, then you'll risk permanent damage to these cells. So usually the best time to give is 24 hours after methotrexate administration. And then of course you have to watch out for its toxicities, which are mostly allergic toxicities, so anaphylaxis and urticaria. Then, of course, as you can probably tell from how intense these toxicities are, it's basically a critical care setting. So this requires a lot of input from the facility itself in terms of equipment and personnel. We have talked about bucket lymphoma. I'll just give a quick management summary for precursor lymphoblastic lymphoma or leukemia management. So these ones share many biologic and therapeutic features with acute lymphoblastic leukemia, and they are thought to be different clinical presentations of the same disease. So it's more common to have precursor T-cell lymphoblastic lymphoma or leukemia compared to precursor B-cell, the precursor B-cell variant. So typically they present with enlarging cervical or mediastinal lymphadenopathy, and the standard of care for treatment is usually, again, combined chemotherapy regimens based on the ALL treatment, including an induction, consolidation, maintenance, and CNS-directed prophylaxis prophylaxis. So outcome when frontline therapy fails in these lymphomas is dismal. Then for diffuse large B-cell management, it's very common. It's very similar to bucket lymphoma. Yeah, so again, in children, it's germinal cell or germinal center phenotype, and it shows some differences in molecular and biologic characteristics compared to the adults. So the difference between that and bucket again will be the BCL2, which is an anti-apoptotic protein, which is expressed in DLBCL when you do molecular studies. So it will present with a rapidly enlarging mass, and usually it will present at an advanced stage. It's typically aggressive, and treatment is identical to that of bucket, but there are still studies aiming towards reducing CNS prophylaxis for these patients, as there's been a lot of toxicity, especially with the use of both intrathecal methotrexate and systemic high-dose methotrexate on the CNS. There's a lot of neurotoxicity seen in these patients because of what I've mentioned, the IT methotrexate as well as the systemic high-dose methotrexate. So again, when frontline therapy fails, the outcome is poor, even though it's slightly better than that in bucket leukemia. When the frontline therapy fails, it's still poor. For the mature T-cell non-Hodgkin lymphoma, I thought it's important to mention the anaplastic large cell lymphoma. So it was initially described as a clinical pathologic variant of the large cell lymphoma, which had an aptitude for children. It's quite rare, and it's associated with a translocation 2-5, which results in a gene fusion combining the NPM and ALK genes, which then facilitate oncogenic transformation. So the morphologic spectrum is characterized by anaplasia, and that is, you can get that even from the name, with the classic subtype being a large horseshoe-like hallmark cells, typically CD30 positive and CD45 positive and ALK positive in up to 60%, but it's usually CD15 negative. So I don't know if it's clear from this slide. I don't know if you can see my cursor, but these are typical anaplastic large cell lymphoma morphology, which shows the nucleus looking, okay, it takes an eye of faith, but the nucleus is essentially shaped like a horseshoe, like a C shape. Again, eye of faith, but the pathologists have even bigger eyes with bigger faith, so they're able to diagnose these things for us. So majority again present with advanced disease, but it's uncommon to have bone marrow and CNS disease. Treatment usually involves the use of adriamycin, prednisone, and vincristine-based regimens for induction, which are then followed by a vinblastine maintenance phase. And then when there is relapse disease, there is the role of immunotherapy by way of crizotinib and brentuximab vedotin. I don't know how available these are in our setting, but I can guess they're not widely available. In terms of summary of its management, again, clinical presentation is variable, but may include both nodal and extranodal involvement, and may also involve the skin. So you can also have cutaneous ALCL. It's been difficult to demonstrate superiority of treatment approach and outcome for the newly diagnosed patients, and it's still inferior to bucket and diffuse large B cell or even lymphoblastic lymphoma. Again, outcome and frontline therapy fails is actually better compared to other aggressive pediatric non-Hodgkin lymphoma. And in some cases, single agent therapy can be effective. So the take-home message from this short discussion has been that non-Hodgkin lymphoma in childhood are aggressive tumors, and it's important that we refer these patients quickly upon suspicion of a diagnosis, as this will save their lives. The chemotherapy regimens are available and good outcomes are possible, but it's important to always have in mind that there's a high risk of oncologic emergencies, and in that regard, you're supposed to we should then be very keen to mitigate these emergencies. As with many other childhood malignancies, multidisciplinary approach will still stand, and this involves the use of pathology, service, surgery, radiology, radiation oncology. Nutrition cannot be understated or undermined. Lab and BTU services, infectious disease services, critical care, as well as palliative and psychosocial service support. Thank you.
Thank you so much, Dr.
Misori.
Bernice. Yes,
Thank
thank you so much, Dr. Mukuria, for that quite elaborate and insightful presentation on non-Hodgkin's lymphoma. It's quite a wide topic, but I think you did justice by highlighting on the most important bits in terms of diagnosis and treatment. So in the interest of time, I would like to invite our second presenter. So I would ask Celine to please share her screen. So Celine Kilanya is an oncology nurse at Kenyatta National Hospital, specializing in pediatric hematology oncology unit. She holds a bachelor's degree in nursing sciences and a master of science in oncology nursing, both from the University of Nairobi. With a deep passion for childhood cancer care, Celine is committed to improving patient outcomes through her daily practice in nursing. In addition to her clinical work, Celine is actively involved in nursing education and research, particularly in pediatric oncology. Her efforts are geared towards enhancing the quality of care for childhood cancer patients at Kenyatta National Hospital, and she's dedicated to her profession. Her dedication to her profession is driven by a strong sense of purpose and continuous desire to make a positive impact in the lives of her patient. So I would like to welcome Celine, and just to remind us, the question and answer session, you can post your questions in the Q&A section, and we'll take all the questions at the end of this session. Thank you.
Thank you, Dr. Brenda. Can you hear me?
Yeah, please. Yeah, please go ahead.
Thank you. Thank you. So good evening, everyone. It's a privilege to welcome you to today's webinar as we gather to explore the critical and pertinent topic of pediatric oncology, specifically non-Hodgkin's lymphoma. As we mark Childhood Cancer Awareness Month, it's important to reflect on the profound impact that this disease, non-Hodgkin's lymphoma, has on our patients, especially for those of us who are practicing. It's not just a diagnosis, it's a life-altering event that demands not only medical expertise, but also compassionate and comprehensive care. So without further ado, I will start my presentation. So this is an introduction of my presentation on nursing considerations. It's the third most common cancer. Non-Hodgkin's lymphoma is the third most common cancer in children, characterized by the malignant proliferation of lymphoid cells, just as Dr. Bernice had informed us. And unlike Hodgkin's lymphoma, NHL tends to be more aggressive and requires more prompt treatment. So the nursing role when it comes to management of our patients is multifaceted. It involves direct patient care, family education, psychosocial support, and coordination of the complex treatment plans. And this presentation focuses on evidence-based nursing practice to optimize outcomes for children with non-Hodgkin's lymphoma. And I'm willing to receive your questions and also your input from that are different setups. So the clinical presentation Dr. had already presented, so I won't get much into that because of time. I'll just go straight to our nursing considerations. So for this patient, one of the most important things is management of, as in monitoring these patients. Regular monitoring of vital signs from the moment of admission and every single day, basically including the temperature, heart rate, respiratory rate, the blood pressure, very important. At the moment, we're getting into the PU's management of pediatric patients, especially pediatric oncology patients. The PU's basically just pediatric early warning signs, whereby you're supposed to be monitoring these patients through their vital signs and even through their neurological presentation using the AVPU setup. We check on the patient whether the patient is alert, whether is responding to pain, unconscious, or responding to verbal cues. So in children with non-Hodgkin lymphoma, they are at high risk for infections, febrile neutropenia, and also other complications which we'll get into. So these patients also require focused assessments. Depending on the stage and the treatment phase, nurses and the whole team actually should conduct a focused assessment. And for example, assess for signs of respiratory distress, just as Dr. had informed us earlier. In these patients, for example, the ones who have mediastinal masses or symptoms of abdominal distension and pain in those with abdominal involvement. So we're also supposed to assess how the patient is presenting physically. You need to be doing daily head and tutu assessments through our triage, the daily triage when you get to receive this patient, when you get to see this patient, by regularly evaluating the child's overall condition, focusing on areas commonly affected by non-Hodgkin lymphoma, such as the lymph nodes that we've been informed, the abdomen for masses or organomegaly. You check on the skin. Do you have pallor? Is there any bruising? Also check on the neurological status, just as I've informed you, especially if there's CNS involvement, which is suspected. Also, early detection of complications. We need to be vigilant for the early signs of oncological emergencies, which we'll get into shortly, just as we've been informed earlier about tumor lysis syndrome, superior vena cava syndrome, and spinal cord compression, which we'll be getting into that shortly. So for the lab monitoring, as nurses, we're supposed to be conversant with the lab works of the patient. For example, the complete blood count in any differentials. We're supposed to be able to monitor the white blood cell count, the hemoglobin count, the hematocrit, the platelet levels, to check whether we're in neutropenia, whether we're in thrombocytopenia, which may be affected both by the disease and also by the treatment, because as we remember, chemotherapy is also myelosuppressive, so we definitely expect this. We're also supposed to be conversant with the monitoring and the electrolytes and the renal function by regularly assessing the urea, the potassiums. This is where now we come by monitoring these electrolytes in order to check on the tumor lysis syndrome, which we'll get into shortly. So as we assess these electrolytes, especially during the initial treatment phase, in order to detect early signs of tumor lysis syndrome and also monitoring of renal function to prevent nephrotoxicity from chemotherapy. Just as we've been informed, most of these chemotherapies, they have these adverse effects like methotrexate being nephrotoxic. So we need to be able to monitor this. As we've also been informed about liver function tests, very important. We're supposed to be conversant with these too, because if there are any derangements in the liver enzymes or the bilirubin levels because of the chemotherapy agents, which basically cause hepatotoxicity, like high-dose methotrexate, we're supposed to be able to monitor this early enough to be able to give an intervention as soon as possible. So one of the main cares or nursing considerations when it comes to the care of the patient is administration of chemotherapy, which I believe happens in most of our settings. So we're supposed to be able to handle chemotherapy safely. Preparation, of course, it comes, most of our chemos in most of our setups, like Kenyatta National Hospital, MTRH, I believe most of the chemotherapies usually come when they're already prepared. So preparation doesn't get it. We don't get too much into preparation, but safe handling, that's where we come in. So as a nurse or even as a doctor, the healthcare provider, we must adhere to strict protocols for the safe handling, preparation, and administration of chemotherapeutic agents in order to prevent exposure to ourselves and also to ensure patient safety. because as we can remember, chemotherapy is a hazardous drug. So they had a hazardous component. So we're supposed to ensure that we protect yourself, you protect the patient, and you protect the environment. So we need to ensure that we always double check. We ensure double checking of protocols, just the way we usually do double checking of blood transfusion before you get to administer blood products. You have to double check it. So I believe that all the institutions, like in Kenyatta National Hospital, we have institution-specific protocols which require double checking of chemotherapy dosages, the routes, and patient identification with the second nurse. And that is what is supposed to happen ideally, because this is a hazardous component, and we already know the side effects and the probability of it bringing, secondary cancers and all, but we're supposed to ensure that you're giving the right dose and the right route, observing all the 5 rights of the patient before doing drug administration. So when it comes also to intravenous access, very important, we are supposed to be able to ensure a central line management, because these patients, they often require central venous access. I believe the setups are different. If they're able to have a portacat, a chemopod specifically for chemotherapy, that is actually the best practice. And we should be skilled. Both the nurse, the clinical officer, the doctor should be skilled in the care and maintenance of these central lines to prevent both infections, blockages, and thrombosis. So in most of our setups, you find that we usually use the peripheral IV management. And these IV lines are the ones which are used. So we're supposed to ensure that there's proper insertion technique, and secure the site and monitor for signs of infiltration, extravasation, very, very important, or phlebitis, because for drugs like doxorubicin or vesicants, we're supposed to ensure that we get to monitor them and see if there are any challenges. So the other point, very important point when it comes to nursing consideration, is pre-medication and supportive care. We know that with chemotherapy, one of the major side effects is nausea and vomiting. So antiemetics are very important. Supposed to administer as prophylaxis in order to prevent the chemotherapy-induced nausea and vomiting, which you all know is quite problematic for our patients. So we're supposed to tailor the antiemetic therapy based on the hematogenic potential of the chemotherapeutic agents being used, because if you get to compare the different drugs, some of them cause like crazy nausea and vomiting, but others can be minimal. When it comes to hydration, we have to ensure adequate hydration before chemotherapy administration, during, and even after chemo to reduce the risk of nephrotoxicity and assist in the prevention of tumor lysis syndrome, just as we've discussed earlier about methotrexate-induced nephrotoxicity. We're also supposed to monitor for the side effects, continuously monitoring the patient for both immediate and delayed side effects of chemo, such as nausea, as I've said before, mucositis, especially with the high dose methotrexate, it causes grade 4, even from 3 to 4 levels of mucositis, which you need to manage promptly. And if it's possible to prevent it, the better. If not, then it should be able to be managed as soon as possible. Myelosuppression, of course, as I've said, cytarabine syndrome, especially since we usually also use high-dose cytarabine, and alopecia, which is also sometimes problematic for our patients. Now, we had mentioned about urine alkalization from the high-dose methotrexate. So the main reason why we need this is because methotrexate usually lowers the urine pH, hence leading to drug precipitation in kidneys, hence leading to kidney damage, which is something which we really need to avoid, because this is when nephrotoxicity comes in. So just as Dr. had informed us, basically through administration of sodium bicarbonate. In fact, it's actually recommended that when you're administering methotrexate, the patient should be having at least 2 pots. If it's possible, if the peripheral lines, like 2 lines, one which is you continue with that administration of sodium bicarbonate, which ideally is supposed to be administered before methotrexate, during the administration, and after, in order to ensure that you are maintaining the urine alkalization. And also hyperhydration, as she has also mentioned, and administration of course, folinic acid. That is the dosage you're supposed to be administering at 24 hours after methotrexate administration is very, very important. So when it comes to management of the oncological emergencies, very, very important also as a nursing consideration. Just as I've said, this is just an overview of what exactly it is that we usually deal with when it comes to oncological emergencies, especially in non-Hodgkin's lymphoma patients, just as Dr. had informed us, tumor lysis syndrome. We need to try as much as possible to prevent this. I believe that in most of our settings, for those of us who have seen us losing patients to tumor lysis syndrome, it's actually quite sad because it can be prevented and managed. So prophylactic measures mainly include aggressive hydration. Aggressive hydration, when we say aggressive hydration, that basically is administration of, if it's normal saline, that's the mainstay type of hydration fluid, and usually give it at 3 liters per meter squared. You have to use the body surface area of the patient, just as you're using the BSA of the patient in calculating the chemotherapy. Is a very same way you're supposed to get to calculate the hydration you're supposed to give. So you get to do aggressive hydration, administration, of course, allopurinol. Allopurinol is what we have mostly in Kenyatta, but Rasmussen case is also available, and also close monitoring the electrolyte levels. Now, what are you supposed to be monitoring for? You're supposed to monitor for the potassium levels. You're supposed to monitor for the uric acid level. You're supposed to monitor for the phosphate level and calcium levels. Because if TLS develops, promptly manage the hyperkalemia. So you'll find that the potassium levels are high and that the uric acid levels are high. You'll also find the phosphate levels are also high, and the inverse proportion of calcium is going to be lower, and you're supposed to manage it according to the established protocols, depending on your institution. Another very important oncological emergency situation will be able to manage is febrile neutropenia, because you can remember that the cancer itself and the chemotherapy cause myelosuppression. So you definitely expect that's why you're supposed to ensure that you monitor the CBC, the complete blood count, check on the neutrophil count. Febrile neutropenia is an oncological emergency. Hence, you're supposed to ensure that you initiate broad spectrum antibiotics within an hour of identifying a fever in a neutropenic patient. And ideally, we usually say it's the golden hour, whereby you're supposed to act as soon as possible, because we have actually lost patients to febrile neutropenia. So within this golden hour, you're actually ideally supposed to do a blood workup, of course, draw blood for a blood culture, and at the same time also ensure that you're also initiating your broad spectrum antibiotics. I know that it depends on the setup. There are those who insist that we should start off with a blood culture first, and another arm saying that we're supposed to start off the broad spectrum antibiotics, but it depends on the setup. But the most important thing which you need to take home is initiation of the broad spectrum antibiotics as soon as possible. I know for the nurse probably who's working on night shift might be a challenge sometimes, because you're probably working, you find that the patient has a fever, signs of infection, you probably get to call the doctors on call, you get to do a CBC, find out we have an absolute neutrophil count which is really, really low. We're definitely having a neutropenia, and you're supposed to start off an antibiotic as soon as possible. So at that time, you're supposed to even call, make a phone call so that you can be able to start off treatment as soon as possible. And that's where multidisciplinary collaboration comes in. So for the neutropenic precautions, supposed to implement these in order to reduce the risk of infection. This includes maintaining a clean environment, trying as much as possible to limit visitors, and using strict hand hygiene. In the setup where I work, we have both parents and the children there. So we have to ensure that we're doing, infection prevention, health education over and over to the parents, and even ensure that you actually limit the visitors. It might, rub others, the wrong way, but at the end of the day, you're looking at the well-being of the patient. When it comes to superior vena cava syndrome, very, very important to also monitor for. We should be alert for the signs of superior vena cava syndrome, such as facial swelling, cyanosis, dyspnea, or distended neck veins, particularly in patients with the mediastinal mass. And how you're supposed to intervene, basically just ensure that you elevate the head of the bed, administer corticosteroids, sometimes you even have to also administer furosemide, and prepare for possible emergency interventions such as radiation therapy, as we have been informed earlier, or emergency chemotherapy, in order to try as much as possible to reduce the mass which is compressing the superior vena cava. When it comes to symptom management, supposed to regular assess by utilizing the age-appropriate pain scales. If it's a FLAC scale, if it's a FACE scale, if it's a numerical scale, this is actually something which we need to make sure that it is a practice. We usually call pain as the fifth vital sign. And we have to ensure that when you're triaging the patient, when you're meeting the patient, maybe when you're starting off your shift or just coming in, when you're starting to see what you're dealing with each and every day, or as you get to monitor for the main vital signs, if it's temperature, if it's pulse rate, if it's the BP, the AVP, you should also monitor for you should also assess for pain, because as pain is a fifth vital sign, we have to ensure that the patient is completely free from pain. We have to always target pain relief for these children, because you can imagine all the challenges they are going through and then pain on top of it. And as a patient is in pain, you definitely not expect this child to be able to feed, this child will not be able to play. And we usually say play to a child is like work to an adult. So play is really, really important to a child. So if they're in pain, they'll definitely not play. They'll definitely not be able to feed. So the general outcome of the patient is not going to be the best. So we really need to assess for this and ensure that we address it as soon as possible. How do we address this? Through analgesics. Administer the analgesics as prescribed using the WHO ladder. So it's supposed to include opioids for moderate to severe pain, while monitoring for the potential side effects and constipation, of course, where we usually give lactulose or osmolax, whatever it is that you have in your institution. Also monitor for respiratory depression or sedation. So we have to ensure that we assess these the dosage of this drug, because most of the time you find if you're using the WHO ladder, of course you start off with paracetamol. It's not working so well, you get to go now to, if it's moderate to severe pain, you have to include morphine, and that's the preparation which we have. And of course of late there has been a morphine shortage, which is quite a challenge, and you can discuss on that. So we have to ensure that if there's no pain relief, let's look at the dosage. Let's have a multidisciplinary team meeting and address this so that we can ensure that this patient is completely free from pain. We should also try and use also non-pharmacological interventions, like implementing distraction techniques for the kids, relaxation exercises, and this is where the child life specialist also comes in, to be able just to assist in implementing these exercises, and also psychological support to help manage the pain. So mucositis is a major issue, and we usually say as much as possible try and prevent it, and if not prevent it, then manage it as soon as possible, because this is a child who is already on chemotherapy. The non-Hodgkin's lymphoma is of course taking a toll on the child's body. So we really need to ensure that the nutritional status is optimal. So in prevention, oral care, encourage frequent, gentle oral hygiene to prevent and manage mucositis, like using a soft bristoled toothbrush and an alcoholic mouthwash or sodium bicarbonate, which is actually readily available in the supermarket or wherever. And this can actually be used, and it's actually even the evidence-based practice, which actually shows it has really good outcomes. For the topical agents, you're supposed to administer topical anesthetics or protective agents to relieve mucositis pain. Consider using a systemic analgesic for severe cases. For a very severe case, we are supposed to use morphine, by the way, for when it comes to pain. Of course, you're using, of course, observing the WHO ladder. And for our setup, we usually have a mouthwash called the Magic mouthwash, which mainly includes lignocaine, it includes gastrogel as a base. It also includes Puriton, chlorpheniramine, and dexamethasone. Those four are combined, and it has really good effects, because now this is on lignocaine. Lignocaine, of course, now it acts as a local anesthetic. And it had really good outcomes for our patients, but it depends now on the setup, on your setting, wherever it is that you are, and it really has good outcomes. Now, for nutritional support, we should try and provide soft, bland, and cool foods, because of course we know that if something is, when it comes to the citrus foods and the like, it might cause more irritation and the child might not be able to eat, just to minimize discomfort while eating. And in severe cases, to consider enteral feeding. When it comes to gastrointestinal support, we've spoken about nausea and vomiting, which is a common side effect in chemo administration. Administer antiemetics based on the patient's hematogenic risk, as I've said. Diarrhea We've seen this quite a number of times, and you're supposed to monitor the stool output, provide antidiarrheal medication that's prescribed, and ensure hydration, which is the most important. You do not want this child to die because of hypotension. So we have to ensure that you get to monitor for diarrhea, monitor the patient for how is the hydration status. Let us not forget that before this cancer comes in, this is a child. And there comes a time when you actually have to use, the pediatric protocol and see how you're supposed to manage some dehydration and severe dehydration in order to ensure that this patient gets to survive. Constipation is also another challenge, which can actually come as a chemo side effect, and you're supposed to administer the stool softeners or laxatives as needed and encourage dietary fiber and hydration. Very, very important. So another nursing consideration which is really, really important, is psychosocial support. Supposed to offer support, emotional support for both the patient and the parent, because as we all know, for a parent, if the parent is not psychologically stable or psychosocially stable, then the child is definitely going to be able to detect this, and this has actually been proven to have some negative outcomes. So we need to support the child, we need to support the whole family by engaging in therapeutic communication, providing reassurance and information to the parents and the caregivers to the patient, because when they have information, trust me, you will actually see that they make better informed decisions. Hence, it gets to influence the outcome of the patient. And we should try and encourage the expression of feelings and the fears, because when we get to expound everything that is involving the child or involving the family, if they're having socioeconomic issues, if they're having troubles at home, relation wise, and you're able to enable them to expound and link them to other support centers or other support systems, you'll actually see that this patient is not going to default treatment and is going to it really, really it gets to just give the outcome of the patient's condition. It just becomes very much better. Psychosocial interventions, mainly by involving the child as specialists to provide age-appropriate activities and support, and also consider psychological counseling for the parents and also the patients, of course, depending on the ages, because you're dealing with children, you're dealing with adolescents, and even to some extent to deal with young adults. So we need to deal with all these things, because when they get to exhibit signs of anxiety or depression or trauma, because when it comes to chemo and cancer, it has a traumatizing effect. So these are the issues which we really need to address in order to have better outcomes. Family support, as I've said, educating the family about the condition, what treatment options do we have, the potential side effects, and even the prognosis. What do we expect? Or do we expect cure? Is it more palliation? Is it more of end of life care? We need to expound all this so that they can be able to have better information. And also very important to provide clear instructions on home care and recognizing complications, because when they're able to recognize the complications, they'll be able to come as soon as possible. And also going to be able to seek emergency care, because you can find that, like today when I was working, we actually found out that there's a child who was staying home for like almost 3 weeks and came back in cancer cachexia. Why? Because the patient had mucositis. The mother was just like, I was trying to feed her, but she didn't want to feed. So I was just, buying time until the date when the patient is supposed to be coming. But the moment that she noticed that the patient is not feeding, and if you can remember, when we manage pediatric patients, when a child is not able to feed, that's already a danger sign. The child should be taken to hospital. So these are the things which you need to get to inform our patients and their families. Coping support, offering resources such as support groups. We need to have support groups, by the way, when it comes to pediatric oncology. We need to have support groups if we decide it's going to be according to the conditions, like for the way it is for adults. We have breast cancer support group, prostate cancer support groups. We really need to look into this depending on our setups. Counseling is very important. Linking to social work, social services is very important. And also to help the family to cope with the emotional and financial stresses of the child's illness, because we all know the financial stresses that we have when it comes to pediatric oncology. Also involvement in care, encourage the family involvement in the care process, allowing them to participate in decision making and caring as possible. Nutrition, I think I've informed you about that. It's very, very important to monitor for the side effects, because if the child has nausea, vomiting, mucositis, they won't be able to feed, and sometimes they won't even be able to say. So we really need to make this assessment and link up with the dietitian or the nutritionist in order to have, a tailor-made nutritional plan. Feeding support, if the patient is able to feed orally, encourage oral intake of preferred but nutritious foods. We can make sure that we encourage small, frequent meals, which may be more tolerable than larger ones. And I think we've all been able to encounter this in our setup. Enteral feeding. In cases of severe mucositis or poor oral intake, initiate enteral feeding to maintain nutritional status. Though sometimes severe mucositis and NG tube feeds can be a bit of a challenge, so you need a multidisciplinary team meeting so that you can be able to make the best decision for this patient, and also monitoring the weight and growth parameters so that you can know when malnutrition is setting in and cancer cachexia. Infection prevention, we've spoken about that. Hand hygiene is very important for both us, the parents, and the patient. And observing aseptic technique in all procedures, especially when accessing lines, handling dressings, or administering medications, because as we know, this is a child who has myelosuppression from the chemo and from the cancer itself. So we really need to try as much as possible to prevent infections. Environmental control, ensuring clean environment, minimizing exposure to infectious agents, and enforcing neutropenic precautions when necessary. Limiting visitors, avoiding the fruit salads which are sold all around, and such like matters. When it comes to vaccinations, live vaccines are generally contraindicated during chemotherapy. When it comes to infection surveillance, supposed to monitor for signs and symptoms of infection throughout, including fever, chills. Those I believe we are conversant with. So education, just as I've mentioned before, we need to educate our parents, we need to educate the caregivers, we need to educate the patients too. They have to know what disease do they have, what is the treatment plan, what are the potential side effects, and the importance of adherence to therapy, because you cannot expect to have successes if we do not adhere to the therapy. And also we get to identify what challenges are the parents experiencing, if they're socioeconomic issues, if they're financial issues, which might prevent them from coming back for treatment, coming back for clinic, for follow-ups. It's very important to be able to expound all this. And this is where also patient navigation comes in, which has been really, really successful when it comes to the adult patients. And they get to be linked to areas where these gaps can be bridged. And we have to ensure as much as possible to use clear, simple language and provide written materials as needed. Because there are very many times when you find that you've spoken so many things, so much jargon, the parent hasn't understood what is happening, and they just get to end up, making decisions which are not in favor of the patient. Home care instructions, as I've mentioned, is very, very important. Discharge planning. You have to develop a comprehensive discharge plan that includes the follow-up appointments, home care instructions, and contact information of the healthcare team. It's very important for them to have our contact so that they can always be able to call. They have someone to consult and to be able to guide them. For long-term follow-up, we have to speak to the parents and even the patients that after completing treatment, continue monitoring for late effects such as cardiotoxicities. We know this comes even earlier when it comes to drugs like doxorubicin, which is cardiotoxic, and ideally we're supposed to be monitoring the cardiologic status, by ensuring that you monitor for the echo. We do an echo before the patient commences doxorubicin administration, and every 3 months, so that the moment that it gets to be noticed, we can have a team meeting and discuss on which drug regimens can be interchanged. Also, neurocognitive deficits. This is actually common with the chemotherapy administrations. Secondary malignancies, very common. Endocrine dysfunctions, because these drugs, they get to affect like all different types of different organs in the body. And you should also be able to schedule regular follow-up visits and necessary investigation. So for rehabilitation services, something sometimes gets to be overlooked. Supposed to refer the patient for appropriate rehabilitation services if needed, including physical therapy, occupational therapy, and cognitive rehabilitation. When it comes to psychosocial and educational support, you've spoken about that so much. So, but we need to also remember that we have successes, we have survivors. And for these survivors, we need to get to a point whereby we have peer support groups and also a transition to adult care. As a child ages, we should plan for the transition to adult care providers who are knowledgeable about the late effects of pediatric non-Hodgkin's lymphoma treatment. Multidisciplinary team approach cannot say enough about this. It's very important to work in collegiality and in collaboration with the whole team. Very, very important. And we have to ensure that we have consistent and clear communication among the team members, because we're all working together to ensure that this patient gets the best treatment and the best outcome depending on the prognosis. Advocacy is also very important. We should promote now, like this is the month, this is Childhood Cancer Awareness Month. We should try as much as possible to promote awareness about childhood cancer and also about non-Hodgkin's lymphoma, and emphasize the importance of early diagnosis and access to specialized care, because unfortunately for pediatric oncology and childhood cancers, they usually present like the common illnesses. Someone might think it's malaria, someone might think it's anything, and you might very, very easily, if you do not have a high index of suspicion, it can just be seen as any other condition. Then they get to continue treatment, or they just get to be lost to follow-up, and then by the time they get to come to the hospital, it has already metastasized. It's already in stage 4 and very poor prognosis. So if we could be able to do screening, then we probably would have, but now we cannot do screening. So we just have to emphasize the importance of early diagnosis and access to specialized care. The other very, very important consideration is research and quality improvement, which the whole team, the nurses, the clinical officers, the nutritionists, we need to look into research, because we do not have enough data to be able to support better care, because what we're looking at is best practices in order to have as many survivors as we can. Evidence-based practice is very important. We have to stay informed. We should stay updated on the latest research, latest treatment protocols, and best practices for these patients, and engage in continuous education and professional development, because with the information, there's power to make the right decisions. Participate in research, very, very important. Quality improvement initiatives. We have quite a number which are ongoing in our department as the Pediatric Hematology unit, in order to implement these projects to enhance care and delivery and to reduce treatment-related complications. And basically, the main goal here is to improve patient outcomes. So for my conclusion, nursing care for children with NHL is dynamic. It's a challenging field that requires a blend of clinical expertise and compassionate care, and we need to adhere to evidence-based practice and to strive for quality improvement. And we can make significant impact on the lives of our patients and their families, and we need to observe this month, Childhood Cancer Awareness Month, in order to let us to renew our commitment to providing the highest standard of care for every child diagnosed with this formidable disease. Thank you. Those were my references. Asante Nisan.
Thank you, Celine, for such a wonderful presentation and for reminding us that each of us has a role to play, and we all have to put our effort to make it to improve on our pediatric cancer outcomes. So now, because of time, I will go straight into the Q&A. And I think most of the questions have been answered in the Q&A session. I think we only have a few that have not been answered. And there was one question to Dr. Banis Nkuria. So there is an anonymous attendee who posted and posed a scenario. If a 7-year-old male patient presents to the hospital in respiratory distress and a CT scan showing an anterior mediastinal mass initiated on Burkitt's lymphoma chemotherapy protocol on a preface and Kosuman and responds to the chemotherapy, how would you further manage this patient? Would they still go for a biopsy? And what happens if the mediastinal mass has shrunk post-chemo? And what is the way forward? So Dr. Banis, please take us through that.
All right, thanks, Dr. Brenda. Well, that's a clinical scenario that's not too unique. They tend to, many times, unfortunately, patients come in not like the textbook definitions or descriptions of disease, but unfortunately, usually with a complication or with something that requires for you to think a little bit outside the box. So in this case of a 7-year-old patient coming in with an anterior mediastinal mass with a diagnosis of bucket lymphoma, and also with respiratory distress. So, and has received what? Chemotherapy, prephase chemotherapy,
like
as well as, yes, and
the
a
first
prephase and the
course.
first course. Okay, so the first thing we need to ask is, to assess is the response to that initial therapy. I'm assuming in this case, he's not telling us how the diagnosis has been made. If you have a tissue diagnosis and you proceed with treatment as it is, and then you monitor the clinical response. If there is improvement in respiratory distress, obviously, and the child's general well-being, then that's a positive indicator that we are on the right track. Yeah, then of course there is an assessment of radiologic response. Usually, if you're continuing the protocol, that should be after about 2 treatment courses, depending on the stage of the disease. And then, what was the second part of the question? About biopsy.
Yeah, if they still need to go for a biopsy.
So that's tricky, but not tricky. If they've been diagnosed with bucket based on the clinical and initial diagnostic findings, and there's a favorable response to chemotherapy, then maybe a repeat biopsy will generally not be required. In fact, most times, if there's a response to therapy, there'll not be adequate tissue to actually be able to biopsy. But generally, we would confirm diagnosis through clinical and histological evaluation from the initial biopsy. But now, if for example, the same patient, there's uncertainty with the initial diagnosis, and if the clinical response does not match what we expect for bucket lymphoma, then you might have to do a repeat biopsy to confirm the diagnosis or rule out other possibilities. So I think that would be a systematic way to approach such a case. Then, of course, if things are going well, you continue chemotherapy and you continue giving the supportive care, as has been very eloquently described to us by Celine, and then continue with follow-up and post-treatment planning as per protocol generally. I hope that has answered the question.
Yeah, yes, but I think I have something to add on as well.
Okay.
I've encountered a similar scenario. Actually, a patient who presented with an anterior mediastinal mass because of the emergencies, the situation, we decided to put this patient on a prephase. Yeah, so the mass shrunk as we were waiting to do the chest CT. The mass disappeared and went away. So the only salvage that we have, it's when we did a CSF cytospin, we were able to see the bucket lymphoma cells on that. So again, for these patients, again, if they have the anterior mediastinal mass, I think then there's also the role of doing an FNA if you have huge peripheral lymph nodes. So this is the other place where I think we can put our FNA into practice and not really go through the textbook or a requirement of getting the true cut biopsy or an open biopsy or So yes, so getting a biopsy, and I think if there is response, then it means it's bucket lymphoma. So I think you'll just treat, but then now you have a backup in case you get a relapse later on, then you do not have any tissue diagnosis to rely on and confirm that it was actually buckets that you were treating. So it's quite a challenging scenario as well.
True.
Yeah.
Agreed.
Yeah.
Yes, you can't emphasize the need for a complete staging workup. So yes, that CSF assessment as well as bone marrow assessment. Once the patient is stable, I think there's still a role for that before proceeding with the full treatment plan, especially if you're not sure at the beginning. Especially if the prephase was given for emergency reasons, I think is my understanding of what we're both trying to say.
Yeah. So I think the next question was answered. Thank you, Dr. Banis. Was answered by Dr. Kathy Mwendo. So there was a question asking on how methotrexate regimen is given, and I think that was answered. And then availability and affordability of leucovorin. And the next question was about the pediatric guidelines. So these were, I think Banis handled it, so institutional specific. So you usually go by what the institution or the national protocols that are available in your setting. And then the other question was about establishing the diagnosis and the considerations on whom to perform biopsies, including bone marrow biopsy. And I think that was well answered by Dr. Banis and Dr. Kathy Mwendo. So there are questions for Celine as well. I think I saw something about the formulation of the magic mouthwash. Yes, so somebody was asking about the exact measurements for making the magic mouthwash. Is it safe to swallow? And how would you manage mucositis in young patients, 1 year old or less, who cannot follow instructions when using this mouthwash? So Celine, please, if you can respond to that.
Yeah, thank you. Thank you for the question. So I do not I don't have like the exact dosages for each constituent, the gastrogel, but I believe our very able Dr. Wata is our oncology pharmacist, might be able to address that, so they can be able to advise on the dosages of the chlorpheniramine, for the gastrogel, for the dexamethasone, and the lignocaine. So what we do in our setup, if it's a 1-year-old child and we have to give the patient magic mouthwash. So when it comes, especially, let me just start off with when it comes to supportive care, in order to prevent mucositis and the other side effects, because as you remember, when it comes to chemotherapy side effects, the chemotherapy basically gets to target all fast dividing cells, and the fast dividing cells are the ones you get to see on your nails, your hair, and the whole GI tract. So when it comes to mucositis, we try as much as possible to use nystatin. We do nystatin as a prophylactic. We also use an antiseptic, maybe like povidone or Remedin, which is chlorhexidine solution, just to try as much as possible to prevent any bacterial growth, just as a prophylaxis. But now when the mucositis now sets in, now that's when the magic mouthwash now comes in. So for a 1-year-old patient, what we usually do is we usually use like not a swab, but a soft gauze. You get to dip it in like 5 ml of the magic mouthwash, and you just get to after we've done like the mouth care, you get to apply it around the oral mucosa of the patient. And of course, this is you get to apply it so that it gets to be absorbed in the patient's mouth. So you'll not be able, of course, to inform this child to gargle because they cannot follow instructions. So this is the best evidence-based practice which you've actually seen, and it actually gets to work. So that is what I would recommend for a 1-year-old child, or those who are below 2 who cannot be able to do a gargle. So as for the dosage, I think I would request Dr. Wata, if he's in the forum, he can be able to give us instructions on the dosages. I hope I've answered your question. Thank you.
Thank you, Celine, for your response. I'm told Dr. Wata is on this call, and I would like to request him to please respond to the other part of this question on the dosages. Please, Dr. Wata.
Yeah. Good evening.
Good evening.
So, have a good night. Yeah, on that query. Now, magic mouthwash is something formulated according to institutions. So what we do at KNH, we borrowed one of the formulas that is used at BC Cancer in Canada. But they are basically, people develop different types of formulations for the sake of that. But generally speaking, the formulation will have an anti-inflammatory and analgesic, may or may not have an anesthetic, and now the carrier the carrier vehicle. So the idea is to suit the mucosa to promote healing and to minimize or to control the pain. Now, for what we use the one for BC cancer, which contains an anesthetic, that is lignocaine. So if an infant needs to use, you can use one of the other different ones that does not contain an anesthetic. There are those that do not contain an anesthetic. So because infants may not be able to spit, and you don't want someone to swallow the lignocaine. And so depending on the person, depending on the patient, if you have an infant, then it's important to let us know that this is an infant so that we can use a different formula to prepare the magic mouthwash. In terms of the milligrams, I can send you for like 2 references that we use for the same. Thanks.
Thank you, Dr. Wata. So I think the rest of the questions we have, I think one that I would ask to be responded to by the panel on live was from an anonymous attendee. What happens when blood cultures taken in a patient with persistent febrile neutropenia comes back negative, yet he has been initiated on antibiotics and the neutropenia worsens over time? Dr. Banis, could you please respond to that?
All right, thanks, Dr. Brenda. So yeah, so we're going into the management of febrile neutropenia, and like with all the other emergencies that we have mentioned or discussed in summary, there are protocols for the management of febrile neutropenia. So yes, even if you've not grown anything on culture, we'll still continue to cover the patient with antibiotics, especially if they continue to be profoundly neutropenic. By that I mean if their absolute neutrophil count is less than 200 or 0.2. Then, of course, we continue to monitor the blood counts, and we continue to support the patient. If they need transfusion, be it of platelets, be it of packed red cells, we give them that. We continue the antibiotic, antifungal cover as well. We continue with making sure they're adequately nourished and continue to observe strict infection prevention measures. So once the counts recover, there are protocols for de-escalating from, for example, IV antibiotics, high level or IV antifungals, etc., and going down to prophylactic antibiotic cover if still indicated. There's at points in the cycle when sometimes chemotherapy has to be discontinued because of the intensity of the neutropenia. But again, these are patient specific at different times during treatment. But generally, for the scenario that has been painted, we would continue antibiotics and continue monitoring the counts. Thanks.
Thank you, Dr. Banis. So I think it's very important for us to know that febrile neutropenia is not just basically caused by bacteria, so it could still be caused by a fungus or a virus. So our institutional protocols usually give us a guide on when to add on an antifungal or antiviral. So a negative blood culture does not mean the patient does not have an infection. It could still be viral or a fungal infection. So also examining for the site a focus of infection, look for your oral candidiasis, thrush, yeah. So those are still very, very important as well. So I think the rest of the questions have been answered in the Q&A box. I don't know if there's anyone else with a question that has not been answered. I'm not seeing any that has been unanswered. So at this point, I would like us to, we've come to an end of this interesting webinar, first webinar in preparation for our pre-workshop conference that is to be held on the 24th and 25th of September. So we call upon all of you we have limited slots for in-person attendance, but there will be slots for virtual attendance. So we encourage all of you to register and attend this event so that we can learn together and put our heads together and do what is best for our patients, create awareness wherever we are. Early diagnosis, prompt treatment is very, very important for us to improve our outcomes on pediatric cancer, not only non-Hodgkin's lymphoma, but also for the other pediatric cancers as well. So at this point, I would like to thank all of you for being patient. I think we've gone overboard by about 17 minutes. And I don't know if there is any other question or announcement from the panel. Anything on the CPD points? I've seen a question being asked on CPD points. I don't know if there's anyone who can respond to that question. So looks like there is no response, but I believe they'll get back to you on the CPD point issue. So thank you all and have a lovely night.
Thank you. Good night.
Good night.
Thank you. Thank you so much.